So this is a patient. We're going to move gears to talk a little bit about macular degeneration. Again, I think another area where between optometry and ophthalmology, we're on the front lines of looking at these cases and trying to decide, what level of macular degeneration do they have? Has this patient moved from being, dry macular degeneration to the wet form of the disease? So this is a 92-year-old Hispanic female who comes in with blurred vision. And I remember looking at her. You can see there's a great view in. She's pseudophakic. She's had a history of having metastatic cancer, and I don't recall which one. So she's not in the best of health. And by this time, she's fairly fatigued. So it's obvious she's got changes within her macula. Her vision's 20/40, 20/30. And of course, the question we always ask is, well, is this because of her macular degeneration? Is there something else going on that can account for it? I'll give you a view of her right eye. And so what's nice about a picture is we have the chance to kind of study it, but that's not always the case when you're looking at a patient live and in person, right? Where you've got your lens up, they're a little photophobic, they're moving, they're uncomfortable, and you're, faced with the question, is there any fluid? Do I see any thickening? Has this patient, converted from dry to wet? And of course, if it is wet macular degeneration, that really becomes a game changer. So I remember having a lot of difficulty looking at her macula. In temporal to the fovea, there's a reddish area that I couldn't convince myself, is that a subretinal hemorrhage or is it not? And the macula, looked flat to me. And so, Alexandra, at our institution, to send somebody for a photo and a fluorescein can be quite a process. And I debated whether I wanted to do that because once she goes in the queue, it's an hour, hour and a half, or sometimes two by the time they get the pictures, get the OCT, and come back to see you. And I made the decision, boy, this looks odd enough that let's get photos and an OCT and just really get a good look at this. And I'm glad I did. This is the left eye. Again, you see modeling. The question that, again, I always ask myself, is there any subretinal hemorrhage? Is there any elevation? Do I see anything that could look like choroidal neovascular membrane? And again, I think OCT does a nice job of that. And so when you look at the B scan above, you see that she's not real elevated, but you can see the shallow elevation of the retinal pigment epithelium. And so how do you interpret that image? Suspicious enough? Can you convince yourself that there is a net or not a net when you look at that patient, Alexandra, in the right eye?
I think those patients, like you mentioned, they're a little bit more challenging. A couple things that I do, you have sub-RPE fluid. You might have a trace of subretinal fluid. I like also to look through the whole cube and and I can see here you were kind of looking at different spots, right? You were trying to analyze all the different areas and see if you can find any activity. Based just on this scan, I probably, unless I was worried, and I think you're trying to be in that area where you saw potential hemorrhage. But based just on this scan, I probably wouldn't jump to conclusion that she's exudative at this point. But I think it would be a patient I would be concerned about, especially if I thought there was some hemorrhage, and maybe some additional testing would be useful. Sure. So let's see what you guys did.
So the OCT-A really is what is really most remarkable, because you can see that lacy, really beautiful, classic, well-defined choroidal neovascular membrane that's present. And I think the next slide has both a 6x6 and a 3x3. And what was remarkable is that reddish area that I was most concerned about is its subretinal hemorrhage. It appears to be, it's really one of the main trunks of this choroidal neovascular membrane. And so, always, or not always, but often enough, you're surprised at what you see when you do this type of imaging. And here was a lady, shallow elevation, but yet she's got this very shallow, low-level choroidal neovascular membrane. The left eye, again, similar type of a scan. You see the fluid just above the RPE. So again, very suspicious on the line scan. And when we did the OCT-A, you don't really see the classic choroidal neovascular membrane like we did in the right eye. Regardless, I think, again, from a primary care optometric perspective, this is a patient that we ended up referring to the retinal specialist. And it was interesting. I think Dr. Rosenfeld ended up seeing this patient, and they observed her without treatment. again, with the idea that this membrane, as large as it is, really isn't leaking. It's really providing some nourishment to the sensory retina. And I guess giving her age and the fact that there wasn't a lot of fluid, she ended up being followed, at least for a period of time, without an injection. And I thought that was really very interesting. Any comments?
Yeah, I think it's a kind of a hotly debated topic
Yeah.
within retina, what to do with those patients, because a lot of times we have patients that we find choroidal neovascular membranes on OCT-A, but if they don't really have any signs of exudation, what do you do with those patients? Do we need to treat them? Do we observe them closely? And what does that closely mean? Because if you know, historically, if you saw that patient and they didn't have any fluid, you might say, okay, come back in 6 months. But now that you know there's a choroidal neovascular membrane, do you bring them monthly? And I think the jury is still out on that aspect. But in my personal experience, I would follow that patient much closer,
Yeah,
because I think
course.
they are at risk of exudation. And in the other eye, I know there was a little bit subretinal fluid
Mm-hmm.
too, so I suspect there was a choroidal neovascular membrane there as well.
Sure.
And make sure that we are able to educate that kind of patient about home monitoring as well. I think a lot of patients don't understand that the changes, you know, they think it's kind of a gradual change, but a lot of times, you know, the change to exudative process is very abrupt. And educating them on Emsler grid, educating them on calling if they notice a change. You know, everything these days is also in the prism of the pandemic. And I've seen several patients who said, oh yeah, I noticed a change, but I thought it would get better. And then they come back now a couple months later with significant fluid and even hemorrhage. And it's always disconcerting when you see those patients.
Sure. You know, she's 94, and perhaps if she's 84 or 74, then it becomes a little bit different and not in good health. But again, I agree with everything you say, and I just thought it was a real fascinating and interesting case on every level of being able to, particularly with OCT angiography, to be able to capture an image that was really that good and really fairly spectacular. So let me show another case, and this is, I think, a typical, to some degree, an intermediate macular degeneration case. He's pseudophakic in the left eye, has got a mild cataract in the right eye, and has maintained really pretty good visual acuity for a long time, 2025. So as I said, when I look at these patients clinically, you know, the question is, do I see hemorrhage? Do I see exudate? Do I see any elevation? And that used to be a clinical decision that we would make, and sometimes we would struggle with it. Sometimes we were fairly good at being able to get a great view of the retina and answer that question. In the era of OCT, as we said earlier, really provides an architectural perspective of cross-sectionally looking at the macula. So in this patient, we see kind of these drusenoid, you know, PEDs, if you will, these elevations of the retinal pigment epithelium, but you don't see any subretinal fluid, don't see any subretinal hemorrhage. And so this is a patient that, you know, we've put on a nutritional supplement, an AREDS2 supplement. We follow him, or I follow him, you know, at least every 4 to 6 months, because we know that even though he doesn't have choroidal neovascularization now, I think that risk is high over the next 5 years that he will go on to develop it. So watching him closely, talking about diet, making sure he's on a supplement. Well, here's where it gets interesting. He comes in, this was around Thanksgiving in 2000. In fact, I see him the first week of December, but he was in Orlando with his family, you know, celebrating Thanksgiving, and ends up in a motor vehicle accident. Somebody rear ends him. He ends up with loss of consciousness, hits his head very hard on whether the steering wheel or the dashboard or a combination. He ends up getting airlifted to a local hospital, and he recovers to some degree. But he noticed when he starts coming to and getting a little more oriented that the vision in his right eye has changed. It's a lot worse. So he's gone from 20/25 to down to 21/50. And so this is the view of the right eye and the left eye. And again, the right one being a little bit hazy, I think, because of the cataract. Of course, he's got the same drusen that we had before. That doesn't really look much different. But again, the same question. Now, has he converted to choroidal neovascular membrane? Is there any fluid? And then look in the left eye in mid-periphery, you see these kind of blot hemorrhages. So I ended up doing the OCT again and just kind of looking a little more closely. You might notice just along the superior arcade, close to the nerve, what may be a cotton wool spot, which I think may be very telling. Here's, again, just more wide field images, a montage, which not sure it helps other than you can see in greater detail the hemorrhages in the left eye. And so here's the OCT. And again, you don't see any subretinal fluid, either above the retina, below the retina. You see these same almost drusenoid PEDs in both eyes. But what was interesting, this is the center 5 roster line that I thought was very interesting. When you look a little above that, and this is the scan above, you see within the inner retina this higher reflective area. And so I think this represents ischemia. And given the picture of the left eye with the mid-peripheral hemorrhages, I think what I thought was this probably represents a Purcher's type of a retinopathy where he has compression of the chest and some of the mediators that result in ischemia and almost like maybe a Berlin's or a commotio retina to some degree as well. You get swelling of the photoreceptor cells and ischemia. And I thought that picture, looking at the clinical image, looking at that kind of higher reflective area within the retina, I think is really very telling. Any insights, Alexandra, on that?
I think you're right, Mark. I think it's very cool image, and I wonder if there's, it looks like we might have a cotton wool spot along the superior arcade, but we might have something even a little bit more central, and it's hard to differentiate because he has all this extensive drusen and slightly hazy view. But I think it's, to your point, right? You're trying to differentiate that this patient have a progression of their AMD, or is it something else? And you can counsel the patient that they don't need the injection, at least at this point, and that other processes going on.
So when you look at the OCT angiogram, let me back up a little bit. So this is the 8x8, and you can see those areas where we saw that higher reflection within the B scan of the OCT. You can see that there's, again, low flow, maybe ischemia, and it goes along with that cotton wool spot that you had talked about as well. And again, you don't see anything that, like in the last patient, we saw a classic choroidal neovascular membrane that was present. This is the 8x8 scan, just to look at that a little more carefully. And again, superior, I don't think our pointer shows up here, but there's a little area, focal areas, where you can see that there's low flow. And it really correlated very nicely with what we saw on the B scan OCT. And these are just a few other cuts. This is a little bit of a deeper cut on the OCT angiogram. And so, as I said, I diagnosed him. I thought this was Purcher's. He still had intermediate AMD. I did, send him to a retinal specialist within a couple of weeks. And they agreed with you, Alexandra, that they didn't think he had any progression from intermediate to wet AMD, and he was just followed closely. And so fast forward, that was December when I saw him. Here he is now in June, and his visual acuity has improved from that 2150 back to 2040. And all those changes that we saw earlier, in a sense, have gone away. And I think to some degree that OCT B scan looks very similar to what we saw before, these drusenoid coalesced kind of PEDs, if you will, very shallow. And here's what was kind of troubling to me. This is the 8x8 OCT scan. I wish I would have done a 3x3. That was, I think, the mistake that I made here. And I would ask your opinion, Alexander, temporally there, does that little area represent an early and occult membrane, or is that, just an artifact? Could it be, movement, or, what do you think on looking at that scan?
Yeah, I think it's interesting because if you look at the scans, we talked how there's different layers, right, that you analyze with OCT-A, and you can go from very superficial layer to deeper layers. And you have it on your slide as well. And it looks like this area of concern is more in superficial layers. So it doesn't quite match CMVM. I think I would look very carefully again on the fundus exam, and I might, if I was concerned, I might do a fluorescein angiography. And I think it highlights another use for OCT-A. OCT-A is not supposed to give you all the answers, but it is something you can use to guide you in terms of deciding whether the patient needs additional imaging. And in this case, the question is, he's still 20/40, and is it driven by the cataract? Is it driven by his macular changes? And I think getting an image like this and catching something would probably, I would probably recommend some additional imaging before you recommend doing a cataract surgery.
And just a couple, here's a deeper image that you can see here that, again, there's some hyperfluorescence there, if you will, but I agree. So the question is it from the cataract or is it from the macula? And I ended up doing both. I had him see a retinal specialist just one more time and then have him, then ultimately he's scheduled to have his cataract taken out actually within the next week or two. So we'll see how he progresses.
All right, so this is a case of a 51-year-old female. She's Caucasian, and she initially came with decreased vision in her eye from 2025 to 2040. And I'm going to show you initial presentation first at the 2025 level of vision and then what changed. So this is her OCT. She's 2025. She has mild metamorphopsia. And we can see that she has a significant amount of subretinal fluid and some sub-RPE fluid. And if we can go to next slide, you can see that we obtained some fundus autofluorescence, looking for any guttering. We're concerned for CSR in this patient. She didn't have any significant changes in the right eye, but in this left eye, you see some hyper autofluorescence, suggesting chronicity of the subretinal fluid. And if we can go to the next slide, you can see that we obtained fluorescein angiography that shows some hyperfluorescence, but more consistent with a CSR kind of presentation with kind of this diffuse leakage. So the patient was initially observed. She didn't have any significant complaints. She had good vision, and we thought it was more along the spectrum of the central serous core retinopathy. If you go to the next slide, please. She comes back and now she's 20/40. And we can see that, interestingly, her fluid, and this is not a long period in between the visits, but her fluid has decreased. Her PED is more prominent, and now her vision is decreased as well. And the question is it just from the collapse of the chronic fluid, or if there's something else going on? And we obtained OCT-A in this patient, if you can show on the next slide, and it does show a choroidal neovascular membrane, which I thought was interesting because the face sometimes, in some cases, especially these masquerade cases, are not your classic AMD cases. FA can show some leakage that is a little bit difficult to interpret, to say with certainty if somebody has a choroidal neovascular membrane or if it's just some non-specific leakage from a condition like central serous. And obtaining OCT-A in this case was extremely helpful because we actually started this patient on anti-VEGF treatment. And if you go to the next slide, she comes back and she looks even better in terms of her subretinal fluid, and her vision actually improved back to 2025. And we've continued this patient because every time we tried to extend her without treatment, she actually noticed increase in subretinal fluid and decrease in vision. So I think when it comes to not your classic presentation of AMD, where it might be a CSR or another case complicated by CNV, obtaining OCT-A is very helpful in addition to fluorescein angiography in my practice to confirm a presence of choroidal neovascular membrane and allowing to treat the patient appropriately. Mark, any comments on this case? Have you?
No, those are tough ones. You know, I followed a patient similar to this with Dr. DeBovi, who large PED like that had, maintained good vision for a long time, and it's frustrating. And that patient in particular was a male, very, very type A, and we between a rock and a hard place because they were symptomatic to some degree, even though their vision was still pretty good. But you're like, what do you do about that PED? And your hands are tied a little bit. So,
Yeah,
that's a
I
very
think
interesting.
if you don't have a confirmed CNVM, you know, we usually don't treat them with anti-VEGF. Those are difficult cases, but in this case, it was actually kind of helpful to find it, and the
Yeah.
patient had a good outcome.
Do they have, you know, on that scan, you can have very nice choroidal detail. Do they have a little bit of a pachychoroid or
Exactly,
relative
exactly.
to the right eye or? Yeah.
Yeah, good pickup. She actually had thickened choroid on both sides. She's quite myopic too. So for her, you know, sometimes you see a very thick choroid in these cases. But I think that's a good pickup, Mark. Great. So I want to show one more case, and this is actually now taking the OCT from the clinic to the operating room. And this is a 76-year-old Caucasian male, and he actually came from my cataract colleague who did the cataract surgery. Everything went perfect. And then the patients called and said, "Hey, I haven't been seen well for 2 months." He comes in with count fingers vision in the affected eye, 20/25 vision in the unaffected eye. His pressures are good, and the only ocular history he has is cataract surgery. If we go to the next slide, he is a diabetic. He has high blood pressure. He is on blood thinners as well as the other medications for his chronic medical conditions. And if we go to the next slide, this is the wide field image of the right eye. And you can see that centrally we have this, what looks like an old blood and some both pre-retinal and intraretinal hemorrhages. The next slide is a zoom-in picture, and you can see kind of how this pre-retinal blood, you can see it's pre-retinal because it's obscuring the underlying vessels. It almost looks like a boat shape, but it's so centered on the macula, as opposed to sometimes when we get subhyaloid hemorrhages, it settles a little bit more inferior along the inferior arcade. And if we go to the next pictures, this is the other eye, just to show that the other eye looks completely normal. There's no, on the exam, there's no evidence of diabetic retinopathy, and the OCT is within normal limits. When you go to next slide, this is the affected eye, and this is the scan through the area of that old hemorrhage, and you can see a lot of shadowing. And next picture, please. Now, this is the scans through the superior portion, and you can see that's where the blood used to be, but now has cleared and settled down. And if you can show one more, you can kind of neatly see on this vertical screen the part where the blood is and the clear part. And the question is, which layer is this blood in? And if you trace the layers, it looks like it might be in the sub-ILM space. So you start thinking of what are the conditions that can cause the bleeding, both pre-retinal in this case, in the sub-ILM space, and then intraretinal as we saw in the picture. And if we go to the next slide, we can see we obtained fluorescein angiography, and just fast forward to a couple more, and we can see that along that vessel of the inferior arcade, and one more slide, you can see a very bright area that is consistent with retinal macroaneurysm that probably ruptured and caused this bleeding. In a way, this patient is lucky because the bleeding only happened in the center of the macula, only in the sub-ILM location. So given how the blood has been there for several months, how dense it was, and how it was dehemoglobinized, the thought was that it's probably not gonna go away on its own. So we decided to proceed with a surgical intervention. Next slide, Okay, so this is the video of the surgery, and we're going to use intraoperative OCT to guide us. So I already done pars plana vitrectomy. I did the core, and now I'm doing the peel. I've stained with ICG. I'm using a finesse loop to start the peel, and I'm using intraoperative OCT to confirm our suspicion that the blood is sub-ILM, and it looks like that. There's some shadowing, so you wonder if there's anything that we're missing. And we start peeling the ILM, and you can see how nicely some of the blood comes off with the ILM that we peel with forceps, but there is still some of the blood remaining. And we're going to image again just to make sure that it's all pre-retinal. There's no intraretinal component, that as we peel, we didn't create any distortion because we want to avoid any damage in the foveal region. And I'm very gently aspirating it here with the vitractor. Once again, I don't want to aspirate too hard and create a hole or anything like that. And it comes very nicely. You can also see on the edge of the screen that retinal macroaneurysm, and I'm going to image again, and it looks gorgeous. Luckily, this patient didn't have any involvement of the retina itself, which sometimes can happen with macroaneurysms. And and there's that RAM. So it was, it turned out to be a very elegant solution, and the patient did really well after the surgery.
That's a beautiful case. That's
It's
incredible.
a fun case, yeah.
Yeah, it's gorgeous.
And let's go to the next slide and just show the final outcome. The patient came back to 2030 extremely happy, and you can see the kind of the RAM that is inactive. And you can see that he does have some changes in the retina. There is inferior heme consistent with hypertensive retinopathy, and there's one in the superior portion of his retina as well. But you know, RAMs can present in different ways. A lot of times we just observe them if they're not exudative. I've seen RAMs that cause extensive subretinal blood, and those cases don't do this as well. But I thought it was really neat how we can take the picture from the clinic and take it to the operating room, and how it guided our approach and allow us to do this surgery safely and successfully.